Okay, folks. Good morning, good afternoon, good evening. This is Dr. Kaz, and we're coming in to the second part of Chapter 28, the reproductive system. We're going to remain in the female reproductive system. And I just wanted to pull out this slide here. This is figure 28.6. This is discussing oogenesis. We're going to talk about what happens right between or during the development of both the oocyte, the egg, and the actual follicles. We actually get to kind of track them together here. I'll kind of go through nice and slow each one here. So if we start up here, right in blue, right before birth, this is before the baby comes out of mommy, right? We will see during that development of the fetus will, and we talked about this, how the oogonia, right, are going to mitotically divide. And so these are diploid cells. And what that means is, that means it has, right, 46 chromosomes, or you can say 23 pairs of chromosomes. One pair coming from mom, the other pair coming from dad. So you have 23 chromosomes, maternal chromosomes, and you have 23 paternal chromosomes. And then together that totals 46. So these oogonia is where we are going to see our oocytes come from. So the oogonia will mitotically divide, and then they will transition here, all right? Once those oogonia mitotically divide, they will yield us these primary oocytes. And so all of these, and roughly we discussed this, you'll have about 1.5 million. And this is, again, during fetal development. So while that's going on, you'll have, all right, the oocyte surrounded by a very simplistic form of a follicle. We call it the primordial follicle. It only has one layer of cells surrounding the oocyte here. So we call it a primary oocyte. And what happens is, all right, that primary oocyte is going to immediately engage in meiosis 1, but it stops right at the first phase or stage of meiosis. So it'll stop right in prophase 1. We'll still have those 46 chromosomes there. And so it stays there for quite a long time. Then we arrive into childhood. And you'll notice here, all right, everything's good in childhood, nothing's progressing. We're still stuck in prophase 1. Then, okay, our person of interest comes to age. And that age is when they start to begin puberty. And so roughly, and I mentioned this before in the previous video, about 20 of the primordial follicles are going to be stimulated to start the maturation process. So 20 of these primary follicles, or up to 20, I should say. It's not going to be always 20. It could be 2. It could be 16. It just varies. So we'll start to cause those primary follicles to mature into our secondary follicles. Now you'll notice the whole time between primary follicle, secondary follicle, and even the antral follicle, where the oocyte's pretty much still in the middle, but we start to form that cavity there filled with serous fluid. All of those 3 stages of follicular development, we are still going to see the egg arrested in prophase 1, and so it is still a primary oocyte, and it still has those 46 chromosomes there. All right, so during that maturation process, only one, not every time, there's always exceptions to the rule, but one will transition from an antral follicle to a mature follicle. And that's where we start to see the oocyte get pushed off to the periphery. That serous fluid-filled cavity here starts to get bigger and bigger. And that's what causes that movement of the oocyte. But at this point now, when we're in the mature follicle, right, that oocyte then is going to continue through meiosis 1. It's going to complete meiosis 1, and then it's going to start meiosis 2. And so where we had a cell, the beginning of meiosis, starting with 46 chromosomes, we now end up with 2. So we have a diploid cell, we end up with 2 haploid cells. One of those haploid cells is our secondary oocyte, and it stops meiosis, right, at metaphase 2. Metaphase 2. Whereas the other structure that is yielded, the other daughter cell from meiosis one, we call that a polar body. And basically it's just junk. Right? Our polar bodies is really nothing there. And so eventually that polar body is going to degenerate. Now we call it the first polar body because if you look down here, once our egg is fertilized with sperm, right, we'll complete meiosis 2. And again, meiosis 2, we wind up with 2 daughter cells, right? And they'll each have that 23 chromosomes there. Right, but then that's where we'll come up with that second polar body. Again, it's just some junk there that was yielded from that division there. So back up here, right, we have our mature follicle. We have our oocyte maturing and developing into a secondary oocyte, and it stays at metaphase 2, and it'll stay there until it's fertilized. If it's fertilized, it'll complete meiosis 2. If it's not fertilized, it'll degenerate and just go away. So now we'll see, all right, the mature follicle continues to maturate, and then eventually it bursts. And that is called ovulation. We get a release of our oocyte there and some of that cumulus euphorus surrounding it, and that gets ejected into the fallopian tube. And then our follicle then develops into the corpus luteum, and that's our endocrine gland. It's going to produce, right, some of those hormones, estrogen and progesterone, and they're going to help with the uterine wall development there. Then eventually, either if no implantation occurs, the corpus luteum will degenerate into the corpus albicans, or if implantation does occur, corpus luteum will stay active for a little while longer until the placenta takes over the role. But that's usually in the beginning of the second trimester, so about 3 months out. So you have a couple different possibilities here as to how long the corpus luteum will hang around. But once we're done with the corpus luteum, we don't need it. It eventually will transition into the corpus albicans, just turn into scar tissue, and a lot of that will get resorbed. So take a look at that figure. I hope it helps you out. We've seen this picture before, just to kind of go over it. It's a good idea to see when we're looking here at our gonadotropins. You got follicle stimulating hormone and our luteinizing hormone. You can see they're pretty steady here during the first half here of the cycle. And then about mid-cycle, just before ovulation, you'll see a spike in both. LH big time. We'll call that the LH surge, or a peak in the LH. And that's right before ovulation. That LH surge is what's going to cause that mature follicle to burst, and so the oocyte, the secondary oocyte, gets ejected. We'll go through this in detail here, but again, you can see in the beginning, most part of our cycle here, the egg is in the primary oocyte stage. That's on the wrong other one here. Sorry, this is the follicle here. So we'll have the primary follicle in the beginning, then our secondary follicle, and it transitions into our antral follicle. So again, we've talked about all this stuff. We'll talk about what happens with estrogen and progesterone. You can see you get a nice estrogen spike early on. A lot of this here is going to help with the maturation of the follicle. And we'll talk about some of the other things. And then we'll get a nice secondary surge, again with estrogen, but a lot with progesterone. And this is when we're really trying to, you can see down below here, when we're looking at the uterine wall, you can see it correlates with the big surges here between these two hormones with estrogen and progesterone. We'll start to get the uterine wall to really develop because it's getting ready, okay, for that implantation there. We'll talk about that. All right, so when we're discussing oogenesis in the ovarian cycle, just like there's a beginning for everything, there's an ending to everything. And the end of the ovarian cycle, right, we call that menopause. And technically, a woman has to stop having a cycle for 1 calendar year. During that time, they cannot have a period. If they do, then we have to start the clock over again, but it's a good indication that we're getting close to menopause. All right, so 1 calendar year, no cycles, we call that menopause, right? And again, there's a couple things to mention. Obviously, they can't be pregnant during that time, right? Or have another medical condition that causes menopause. Maybe they're on some medications that have caused that. All right, so usually this happens between the 4th and 5th decade of life, 45 to 55. At that point, remember, right, when you begin puberty, right, we start off with 1.5 million, okay, ovary oocytes, or oogonia, in the developing fetus. And then what will happen is, right, they will undergo what we call atrasia, and you'll lose a majority of them, about 2/3, and you wind up with about 400,000 viable primary oocytes there. And so here we'll see in menopause, no more ovarian follicles will be remaining in the ovaries, left or right. So therefore, if you're no longer having, all right, the ovarian follicles maturing and releasing the oocytes and causing the development of the corpus albicans, right, corpus luteum, then we're not going to get large amounts of progesterone and estrogen being secreted, because we're getting rid of our endocrine gland there. And if we're not producing large amounts or significant amounts of progesterone and estrogen, then the uterine lining is no longer, that functional layer is no longer going to build up, all right, and then shed and tear itself down. So because of that, we will no longer have our periods. So let's talk about how we regulate the ovarian cycle. Yes, it is based upon our hormones. So we're going to start off in our master gland there, up in the hypothalamus. We're going to go all the way up to the diencephalon. Take a look at the hypothalamus as it's releasing gonadotropin releasing hormone. And that gonadotropin releasing hormone is a regulatory hormone that's going to stimulate the anterior pituitary to release follicular stimulating hormone, or excuse me, follicle stimulating hormone and our luteinizing hormone. And so both of those hormones are going to go to the ovaries, and they're going to now start, right, those follicles, those random follicles, to start to mature and develop. And so again, we'll get up to those 20 follicles that will start to undergo that maturation process. And as a result of that, okay, we're going to see maturation going on, but also we're going to see other hormones being secreted, which we're going to talk about: estrogen, progesterone, and inhibin. So as those maturing follicles are developing, they're going to release inhibin and estrogen. Now, estrogen is again going to start to get the lining of the uterus ready, and it's going to also promote the maturation process in those follicles. Meanwhile, inhibin is going to effectively be a negative feedback driver, and it's going to affect the hypothalamus and the anterior pituitary. And so it's going to cause some negative feedback going on there to decrease the release of FSH and LH. Okay, but estrogen, meanwhile, is going to help with the uterus and get that ready. And at the same time, it's going to continue on with the maturation of the ovarian follicles. And so that is actually going to be a positive feedback loop going on. So as that ovarian follicle continues to develop, okay, it's going to drive it into that maturation. And then as it's maturing, it's going to release more estrogen. All right, so now let me just show you this in a picture before I get into that. All right, so here, let's start off in the beginning here. I should have started off with this. Okay, so here is our hypothalamus releasing the gonadotropin releasing hormone. Okay, so releases that, goes to the anterior pituitary, right? GnRH is going to stimulate the anterior pituitary to release FSH and LH. And so now that is going to trigger, right, the maturation of random ovarian follicles. And as a part of that, okay, we're going to result in the production of estrogen from this maturing follicle, and also the production of inhibin. Now, inhibin is going to travel up. It's going to negatively affect the anterior pituitary and our hypothalamus, and cause a decrease in the release of our FSH and LH, and even low levels of estrogen. But now also consider estrogen then is also going to drive the maturation process of the ovarian follicle. And as it does that, it's going to release more estrogen, and it increases, right, the amount of estrogen from low levels to high levels, and that kind of kicks, all right, the machinery back on here. And that's what we're going to talk about here in a moment. We're going to kick on the hypothalamus and kick on the anterior pituitary, and we're going to talk about that now. Okay, so as we kind of kick those machines back on, we're going to see now, right, the anterior pituitary is going to turn up the amount of luteinizing hormone in such a way, we call it the LH surge. And that is going to be when, well, as a result of that LH surge from the anterior pituitary, that is going to be what triggers ovulation, right? Without the surge, this is a great test question, no LH surge, no ovulation. So once that surge occurs, that's usually what people are looking for, right? If they're trying to get pregnant and monitor their cycle and finding out when ovulation occurs, one way to do that is monitor the luteinizing hormone levels. When you see a huge spike in that, then you know, okay, this is the ovulation period. This is the best time to try to get pregnant here. All right, so the LH surge occurs. The mature follicle releases the secondary oocyte into the fallopian tube. And then as a result, now that mature follicle degenerates or transitions into our corpus luteum. And our corpus luteum now is going to be our endocrine gland that is going to turn up and really start to spew out progesterone. Awesome, because progesterone is going to help get the uterine lining ready for implantation. We only have a few days to get ready for that. That's how long it takes, anywhere from 4 to 6 days for the egg to travel from the ovary into the uterus there. And so not only is estrogen going to be released in large amounts, estrogen and inhibin. The first two, again, like I said, they're going to help build up our uterine lining. But again, they'll also cause an inhibitory feedback mechanism onto the hypothalamus and the anterior pituitary. And so again, that stops the release of LH and FSH. Right, because we don't need to start maturing other follicles yet. We got to give this follicle a chance to see if it gets fertilized. Right, we just expelled it. It's now on its way. Let's see, fingers crossed, fertilization occurs. If nothing happens, if no fertilization occurs, well, no issues, because then our corpus luteum will start to degenerate into the corpus albicans, turn into scar tissue. It stops producing progesterone, estrogen, and inhibin. Right, so again, we have our time period of 10 to 13 days for that to occur. Right, so if there's no fertilization, no issues. The cycle will then repeat itself. Right, as a result, we'll start to see our LH levels have reduced. Okay, through that negative feedback. All of the estrogen, like I said, progesterone and inhibin is reduced because of the degeneration of the corpus luteum. And then, of course, the hypothalamus starts to release its gonadotropin-releasing hormone to start the new cycle. But again, it's after the 10 to 13 days. So roughly about 28 days. So if we do get fertilization and if we do get implantation, we need both fertilization and implantation. Now, right, we call the oocyte the preembryo. And so now our preembryo attaches itself onto the wall of the uterus, and it's now going to act like an endocrine gland. And it's going to release a hormone called human chorionic gonadotropin, lovingly known as HCG. And so if you want to find out if you are pregnant, this is the hormone that we detect in the urine, HCG. And so what HCG does, okay, it is going to take over the role of our luteinizing hormone. And so it is going to continue to encourage and stimulate the corpus luteum into releasing those three hormones that I just mentioned, estrogen, progesterone, and then of course inhibin. And so this, again, we already know, all right, estrogen and progesterone are going to help to build and maintain the uterine lining. Okay, we want to make sure we're doing everything possible for that implanted embryo, that preembryo, to strive and start developing into a blastocyst. We'll get into all the different stages of development, but eventually into a fetus and then a baby. Right. Excuse me. So the corpus luteum does this for the first trimester. It's going to act on producing, right, estrogen and progesterone. So it goes for about 3 months. After 3 months, the placenta takes over, and then the corpus luteum goes away, and it turns into the corpus albicans. At that point, we don't need it anymore because the placenta is now producing the progesterone and estrogen. Works out pretty well. So here's that second part of the ovarian cycle here. So you can see, okay, now we have our mature follicle. It's now increasing the amount of estrogen levels from low to high. And so that low to high is then going to stimulate the anterior pituitary to release luteinizing hormone, LH, at large amounts. That LH surge occurs. And as soon as that happens, okay, the maturing follicle ruptures and it expels our secondary oocyte. And so that secondary oocyte moves into the fallopian tubes. Then we can see, right, that ruptured mature follicle is going to convert into the corpus luteum. And then now we have developed our own endocrine gland here temporarily for 3 months. And so the production of those 3 hormones, progesterone, estrogen, and inhibin, will act as, all right, an inhibitory stimulus here on the hypothalamus and the anterior pituitary. So the hypothalamus is no longer producing gonadotropin releasing hormone. And also the anterior pituitary is no longer producing LH, no longer producing FSH. Okay, so we've stopped that process. And this goes on for 3 months, and then eventually our corpus luteum degenerates into the corpus albicans because the placenta has taken over the role. Uterine tubes, uterus and vagina. We're moving to the final part of the female reproductive system here. And so let's start off with the uterine tubes, also known as the fallopian tubes. And so these are the tubes that are going to extend laterally off of the uterus, right? And so they'll go from the medial portion of your pelvis, pelvic cavity, out to the lateral portion there. And so then on the far end of the uterine tubes, right, they will be in close proximity to the ovaries. And so their job is one thing. It is going to be to transport our hopefully viable, right, mature, fully matured oocyte into the uterus. And if we're lucky enough, it'll get fertilized along the way or get fertilized in the uterus there. So the uterine tube, all right, or tubes, excuse me, are covered by this structure called the mesosalpinx. And basically that is part of the broad ligament of the uterus. It's one of the ligaments that holds, oops, I'm going the wrong way, holds the uterus into place. I'll show you real fast here. It's somewhere in here. Here it is, okay? So the mesosalpinx is way over here, right? So here's the ovary. Here's our ovary. And then you can see the uterine tube here extending, right, laterally off of the uterus here, right? And then it is in close proximity here to the ovary. And so this part right in here, this tissue in between, right, the ovarian ligament and between the uterine tube, that's the mesosalpinx there. And it's part of the broad ligament. I always tell folks, imagine the broad ligament as this ligament that drapes over the like a sheet on a clothesline. You know, you throw the sheet over, and so the broad ligament drapes over the uterus and it drapes over the ovarian tubes, or excuse me, the uterine tubes there. Similar, like a sheet draping over a clothesline there. All right, so when we're talking about the very first part of our fallopian or uterine tubes, we refer to that as the infundibulum. And it looks like a funnel-like structure. And so at the end, we have these structures called fimbriae. And they're like fingers, you know, like the fingers coming off of your hand. And so during the time of ovulation, the fimbria will move very close to the ovary, kind of like hover over it. So when, right, the follicle ejects the oocyte out of the ovary, right, the fimbria now kind of slid over the ovary, and so they'll, I hate to say consume, right, but they'll hang over it, and that allows the ovary to move into our fallopian tubes there. So the next part, as that oocyte starts to move through the fallopian tube and heading towards, all right, the uterus, the next part that it comes to is the ampulla. Now, this is where fertilization typically will occur. It can occur at any of those places along the ovarian tubes, or excuse me, I keep saying ovarian, the fallopian tubes, all right, then also inside of the uterus here. But mostly the ampulla is where fertilization will typically take place. Now, as we move more medial towards the uterus, right, we hit the isthmus. And that is the part of the tube just on the outside of the uterus there. Okay, so it's pretty much the part of the tube where you see it connecting to the body of the uterus. And then, of course, that tube will go through the wall of the uterus and then eventually to the internal cavity there of the uterus. And we call that the uterine part of the tube. So literally the uterus will surround, all right, this part of the uterine tube here. So we call it the uterine part of the tube there, right? And so this is the part that goes right through the wall of the uterus. So let's talk about, all right, the layers to the uterus, right? So we have 3 layers. We should be familiar with this because we've seen, right, this nomenclature mentioned before when we talked about the digestive tract and some other areas here and some of our other systems, right? So we have 3 layers, right? We have the mucosa, the muscularis, and the serosa. So the innermost layer is the mucosa, and it's lined with simple ciliated columnar epithelium. Well, this is great because the cilia here are going to start to sweep back and forth, but they're going to sweep that oocyte towards the uterus here. And so this helps move the oocyte, right, into the uterus. Now, underneath the simple ciliated columnar epithelium, we'll have, right, our loose connective tissue, the areolar connective tissue. And what you'll see is, right, the lining here in the mucosa will have these linear folds. So if here's your uterine tube, right, and you have these folds that go along this way. So if I were to take, all right, a transverse cut of it, right, the inside of the tube would kind of look like this. It would be kind of bumpy because of those folds. I'm not doing a very good job, but bear with me. Right? So where I'm drawing this arrow, that's that cavity, that's the space where the oocyte travels down. Right, the second layer, easy to discern what happens there. Muscularis, think of muscles. So you'll have an inner circular layer and the outer longitudinal layer. These muscles, these smooth muscles will contract and relax, and these contractions will help again to move our preembryo, all right, through that uterine tube towards the uterus there, in addition to the cilia sweeping and moving it in that direction. Then our outermost layer, the serosa, okay, since it's called serosa, then we know that the serous membrane is going to be covering, all right, our uterine tube there. So let's get into the uterus here. All right, literally it is a pear-shaped muscular organ. It's upside down pear-shaped, right? And when we talk about it, it's muscular organ. It's because you have a significant amount of smooth muscle, which will assist, right, in the delivery process of the baby. All right, so in the center of the uterus, our lumen there, right, you'll see it's almost kind of like a triangle. And again, this is going to be, bear with my horrible drawing here. That's not too bad. So the uterine tubes will come in through the sides here. And so you're going to have a cavity. It's going to kind of almost be like a triangle, like this. All right, so this is the lumen is where I'm putting this L here. All right, so you'll have, all right, the uterine tubes on either side of the lumen, and then at the bottom here, on the other side of the cervix, is where the vagina is going to be located. All right, so the uterus is normally going to be positioned in what we call an anteverted position. Okay, so for the most part, females will have their uterus laying on top of their bladder, and the body of the uterus is leaning forwards towards the umbilicus. Now, in older folks and older ladies, right, this position can switch, where the body then moves back towards the rectum or your spine. We call that a retroverted uterus there. So what's the job of the uterus? One, okay, is a site for implantation, right? And then if we're lucky enough to have implantation and the development of the fetus there, then it's going to support, protect, and nourish all of those stages of development, right, that our preembryo is going to go through. Then eventually we're going to get the development of the placenta, and this is going to be the organ that helps to keep the fetus alive. Right, it also effectively will eject the fetus at birth. The middle layer, those muscles there will contract and relax, we call those contractions, and they'll help to expel the fetus and move the baby, right, through the birth canal there. If an oocyte is not fertilized, then we will see, right, during menstruation, the shedding of the functional layer, that's the innermost layer of the uterus, and the uterus helps with the shedding by contracting to try to eject it out of the lumen there. And then finally, of course, it is an organ, so it needs blood, so it gets its blood from the uterine arteries that come off the internal iliac artery there. All right, so there are three areas to the uterus: the fundus, the body, and the isthmus. And then the cervix is the inferior most portion. Okay, to me, the cervix looks like a donut. So when we're talking about our uterus here, again, upside down pear-shaped structure. And then at the bottom, again, bear with me, this is not going to be a very good picture. It's not too bad. Could be better though, right? All right. Okay, so here's one uterine tube coming in. Here's the other uterine tube coming in. Okay, so if we're above the two uterine tubes here at the top, this little dome-like structure, that's the fundus. Then the body is going to be this mid portion here. That's going to make up the majority of the uterus. Where it starts to narrow down, this is my best example of the narrowing. That's the isthmus there. All right, and then down here, you have your cervix. All right, and the cervix, think of it like a donut. Okay, so you have a hole in the middle. All right, so the first opening from the uterus towards the vagina, we call that the superior os, or superior cervical os, OS. And then this other opening down here on the side where the vagina is, that is the inferior cervical os. And that's what we're seeing here, okay? So the cervical canal is going to connect both the external, did I say superior and inferior? I apologize. The internal and external. I didn't say right saying that. The internal os and the external os. So the internal os, all right, and the external os are connected to one another through that cervical canal, like a roll of toilet paper. That's what you should be imagining now. Okay, so in the cervix there on the external os, you are going to have this structure called the mucus plug. Now there's tons of mucin secreting glands in and around the external os. And so mucin, as you know, when it mixes with water, turns into mucus. And so this is going to act as a protective mechanism, prevention mechanism for allowing, right, any type of bacterial, any type of pathogen, opportunistic infection pathogen, to gain entrance into the uterus from the vagina. Right now, during the time of ovulation, though, this area will thin out, and that's important. Right, the journey that sperm has to make is a pretty tough journey. That's why, all right, hundreds of millions of sperm are ejected during an ejaculation, right? Because all you need is one. But again, a majority of that sperm just will never make it there. They have to go through several obstacles, and this is one of them. And so during that time of ovulation, that mucus plug, it will thin out. There'll be less mucin being produced, and so it makes it easier, okay, for the sperm to gain entrance, right, into the uterus there. All right, so there's three layers, what we call tunics, to the uterine wall. right? Perimetrium, myometrium, and endometrium. Okay, so those three, you should be familiar with some of the spelling and how this works now. All right, the innermost layer is the endometrium and the outermost layer is the perimetrium. Of course, the middle layer usually pretty significantly is going to contain all the muscle. So the perimetrium is part of the serosa there. And so it becomes contiguous with the broad ligament. That's that sheet hanging over our clothesline that I was talking about earlier. Then we have our myometrium. Again, myo is muscle. In this case, we're going to have 3 layers of muscle on the inside of the uterus in the wall there. And then the innermost layer is the endometrium. And so the endometrium is covered with simple columnar epithelium, no cilia in this case. And of course, underneath our epithelium, we always will have our lamina propria. And then underneath that is usually where we'll start to see, all right, our connective tissue. In our lamina propria, this is where we're going to find all of those glands that I was telling you about, right, that are developing during, okay, the release of progesterone and estrogen. So the endometrium is made up of 2 layers. This is important. The deeper layer, basal, easy to remember because it's on the bottom. So it's the basal layer. This is the permanent layer. This layer is with you all the time. It doesn't go away. Right? It does undergo some changes though during the development of the uterus as we're prepping it for implantation. Okay, but not a lot, not like the other layer, which is the superficial layer. That's the functional layer. Okay, you develop this layer during puberty. And so this is when estrogen and progesterone are being released from the corpus luteum. And prior to that, during the follicular development, when estrogen is being released, it's the functional layer that we are starting to prep and get ready. And so when estrogen and progesterone are released on this functional layer, right, it is going to start to develop, increasing blood vessels, increasing glands there. And so it grows. Now, of course, when there is no fertilization then, during the shedding period, right, during the menstrual period, this is going to be gotten rid of. So the functional layer goes bye-bye. All right, let's talk about the vagina. Okay, so the vagina is the inferior most structural region in the female reproductive tract. Okay, so it is a muscular tube, a fibromuscular tube, right, that is going to connect the uterus to the external environment there. So it plays a couple of roles here. One, it is going to be the birth canal. So during the birthing process, right, unless a C-section is performed, this is where the baby is going to travel out of the uterus into the world. Right? It also is going to be where the penis is going to be inserted during coitus or intercourse. And then finally, this is going to be, all right, where that functional layer during menstruation is going to be shed off and it's going to be expelled through the vagina. So it has those 3 roles there. And so the vagina is supplied by the vaginal arteries, and then easy to remember, it is going to be drained by the vaginal veins there. And so it too has 3 tunics, right? The innermost layer is the mucosal layer, the middle layer, again, muscularis, and the outer layer is not a serosa, but an adventitia. So now the mucosal layer, the innermost layer, is made up of non-keratinized, but notice it's stratified squamous epithelium. Stratified squamous epithelium, we've talked before, are going to be found in areas that undergo mechanical stresses, right? So a lot of friction is going to occur there. Obviously during intercourse, of course, during also childbirth, when the baby is leaving, right? So again, it only makes sense that this layer is going to be non-keratinized, stratified squamous. So there's because it takes a lot of punishment there. All right, just deep to that, we'll in the lamina propria, we'll have our blood vessels, but we have a high amount of blood vessels there. Now, the glands here are going to secrete an acidic secretion. Again, acidic conditions make it a hostile environment for certain pathogens. So the acidic secretions prevent infection, but they also make it a hostile environment for sperm. Okay, so keep that in mind. It's a double-edged sword there. Now, all right, in the inferior portion of the vagina, there are transverse folds. And these transverse folds, right, are going to be kind of like that drawing that I showed you for the fallopian tubes there. We're going to see these transverse folds, and I can't really do a very good job because it'll do something like that. All right, so as we move towards the vaginal opening there, we'll see the transverse folds, all right? They project into the lumen there, but at the distal portion of the vagina, okay, will form what's called the hymen. So these transverse folds form this membranous barrier there. All right, now last two layers, muscularis, okay? Again, it's going to be made up of smooth muscle and outer and inner layer. Then the adventitia, we'll see the elastic fibers. Again, that will help to change the size of the lumen there of the vagina. And then outside of that, we'll have our loose connective tissue, the areolar connective tissue. All right, so this is that picture I was showing you before. Take a quick peek at it so you have a pretty decent idea of all those structures. Okay, so here is our cervix right down here at the bottom. So this is where the mucus plug is going to be located, right there. All right, so let's talk about the uterine cycle. All right, the uterine cycle, excuse me, if we're going to talk about that, we are going to talk about it's also called the menstrual cycle. And then of course, at the end of the uterine/menstrual cycle, we have menstruation, the shedding there of the functional layer. So basically, we're going to be talking about this lining right here, the endometrial lining, the functional layer specifically. And so the hormones that are going to influence these changes are going to be estrogen and progesterone. Right? They are coming off of the corpus luteum for the first 3 months there. And so the uterine cycle, the menstrual cycle, has 3 phases: menstrual phase, the proliferative phase, and the secretory phase. Now, normally on average, it's usually a 28-day cycle, but it can vary, right? Anywhere from 21 to 35, and it can even be different than that. I've met people that don't have a period maybe but once every 3 months. Okay, so it just varies. So the menstrual phase, this is the first part of our cycle, 1 to 5 days of the cycle. This is when we get rid of the old functional layer. There was no fertilization, there was no implantation. Okay, so we get rid of that functional layer, we slough it off, right? And then, so that is going to be, right, that 1 to 5 days you'll hear people say, quote unquote, right, they're bleeding. Then we move into the proliferative phase. Okay, that's days 16 through 14. And so now we just tore down the old layer. Now we're going to build it up again. So now we're going to make a new functional layer. And so again, that starts off with, right, estrogen being secreted, right, from the ovary follicle there. Okay, and it stimulates its own maturation. So during this time, the follicles are growing, maturing, and at the same time, we are producing a new functional layer in the endometrium. That's the proliferative phase. Then the final phase is the secretory phase, day 15 through 28. This is now, all right, we have progesterone being added into our list of hormones that are being released, right, that are going to affect the uterus here. And so the corpus luteum is responsible for that. It's also producing estrogen also, and inhibin. Right? And so because of all this, we are going to see a large increase in vascularization, and all those uterine glands that we were talking about, they're going to be produced there or increased in their development and growth in the functional layer. So of course we know, all right, if fertilization occurs and implantation results from that, then this will see those hormones in higher than normal levels to help sustain and maintain the uterine lining there. If fertilization does not occur, then as you know, the corpus luteum starts to degenerate, and that will decrease, right, estrogen levels, progesterone levels, and inhibin levels. So we'll see a big drop off there in progesterone, and because of that, all right, with no progesterone, then the functional layer is going to degenerate and slough off, and you shed it. during the menstruation period. So again, you can see, it's not that I have a fetish for this, right, that I really do like this. You can see if we look down here, right, during our ovarian hormone levels, here's that first estrogen spike I was talking to you about before. Okay, that's going to be from follicle as it's developing. And then around ovulation, around day 15, we get that LH surge. LH surge occurs. And soon following that, right, because of the LH surge, right, we get the transition from the mature follicle to the corpus luteum. And so the LH surge occurs, the oocyte is ejected, and then we see here we have a large spike in progesterone and then another spike in estrogen. And all of that is going to promote this development here in the uterine lining here, getting that area ready for implantation. Okay, so let's talk about the last part here of our female reproductive anatomy and talk about the mammary glands. All right, the mammary glands, also known as the breast. Okay, so, right, you're going to find those in the thoracic region on the front, on the anterior thoracic wall there. And back in chapter 5 or 4, I can't remember now, a while back, we talked about the different types of glands, the anatomical description, right? So mammary glands are exocrine glands. They have a duct, right? The actual anatomical makeup of these glands, we call those tubulo-alveolar, okay, which means, all right, parts of those glands you'll have are tube-like, okay, but you'll see a swelling there also. And so their job is to produce breast milk. Right? So breast milk is going to be made up of proteins and fats, and some of those proteins and fats are obviously going to be in the actual secretions, but part of that comes from the cells too, because of the type of gland that it is. But we'll also see some lactose. So actually breast milk is high. It's a great source for fat, great source for protein, and you're also getting a carbohydrate from the lactose there, the sugar there. So when we're talking about our mammary glands, we're going to divide them, each mammary gland or breast into lobes, and then we further subdivide those lobes into lobules. So if I show you here, okay, you can see this is a picture. Here's a lobe, one whole thing here. That's the lobe. Okay, and then we can subdivide the lobe into these smaller lobules. Here's one lobule, here's another lobule, here's another one, here's another one. That's what we're looking at. So in the lobules here, right, we'll actually have the secretory portion of the lobules. In the lobules, we call those the alveoli. That's what produces milk. So once, all right, during the development of the fetus and during the pregnancy period there, right, near the latter end of the pregnancy period, we'll start to see, right, an increase in our alveoli, all right, in the mammary glands, all right? And not only that, we'll see a larger number, but they'll become larger in size. And so from the lobules, you'll have a duct that is going to drain into a larger duct, and then eventually we'll talk about it here into the lactiferous ducts. So these lactiferous ducts are going to receive smaller ducts, all right, that come from one single lobe. And at one point, all right, they'll all converge on a specific area, and we call that lactiferous sinus. That is where we're going to store the milk, right? But it can only be stored there for so long, right? So here you can see, here is the lactiferous sinus. This is where we're going to store the milk for a certain period of time. And that's why in mothers, after they've given birth, right, and they're doing the breastfeeding, right? Some women will say if they haven't fed for a while, right, that their breasts are starting to hurt. And that's because those lactiferous sinuses are filling up, and it's putting pressure on other structures there, and it does not feel good. It becomes uncomfortable, and it's time to eject the milk, whether it's through actual nursing or pumping. It's time to get rid of that. Right? So when we actually are going to be nursing, right, we call that process lactation. That's going to be the releasing of that breast milk. And so we're going to see lactation is going to be stimulated either by something internally or externally. Well, externally, that's pretty easy, right? That's going to be during the rooting reflex when the baby, right, wants to feed. And so if it latches onto the nipple there, right, it will cause, all right, lactation to occur, the release of breast milk. Also, though, again, if that lactiferous sinus is filling up, the pressure can eventually also cause, all right, lactation to occur. Certain emotional responses too can cause lactation. There's several things that can occur, right? So this is going to happen after birth, right, lactation. So we're going to involve two hormones, prolactin and oxytocin. Prolactin is made in the anterior pituitary and released from the anterior pituitary. This is what makes the milk, right? This is what also increases the size of the breast because we're going to develop more alveoli and the alveoli grow in size. Now, oxytocin is made, you remember this from chapter 17, oxytocin is made in the hypothalamus, but stored and released from the posterior pituitary. And oxytocin is going to be responsible for milk ejection. So again, we need both, prolactin and oxytocin. All right, so this brings me to the female sexual response, almost done here. All right, so we're a couple different stages here for the female sexual response. The first stage we begin with is the excitement stage. Right? This is where we start to see, right, certain reproductive organs start to fill up with blood. The clitoris, right, the labia, both the labia minora and the labia majora, right, and the bulbs of the vestibule are just a couple of examples of some of those organs that start to fill up with blood. Okay, the nipples become erect, the uterus becomes more erect, again, getting ready, right, to position the uterus there to receive the sperm there. And so then in the birth canal there in the vagina, we'll see an increase in the production of mucus there, one for lubrication, okay? And that will help with, all right, well, so the female doesn't get injured there. And then we'll also see, all right, a constriction going on in the vaginal wall there that will help to accommodate actual the male penis for intercourse. And so because of the excitement here, we know that the excitement is part of the sympathetic nervous system, right? We are going to increase our heart rate, increase blood pressure, and respiratory rate. All things that the sympathetic division of our autonomic nervous system play a role in. Then the next stage is orgasm. During this period here, all right, the female will experience intense pleasure, all right, also a sensation of release, and this causes contraction of the vagina and the uterus here. And this will occur over a period of time. Again, it's to help promote movement of the sperm. And then finally, at the end, we have the resolution phase. And just like the name implies, resolution, everything is going to be resolved. So everything is going to go back to normal. Okay, the uterus goes back to its original position, the vaginal wall relaxes. Okay, blood will then start to leave the tissues that it entered in during that engorgement period there. Right. Now, the thing is, and we'll talk about it when we get into the male sexual response, is after ejaculation, men have what's called the refractory period, in which they can't have another orgasm for a certain period of time. Women, there is no refractory period. Okay, so they can actually have multiple orgasms during that time. All right, that seems like a good place to stop for this video. I hope you enjoy it. You have a great day.